Go ahead. No. Where are you going? Remember, I don't deal with that. Who are you going to talk to? Remember what he said? You were not here. So you have to send an email, and they'll take care of it.
Okay.
It wouldn't be early.
I'm leaving that day, like in the morning.
You have to, as I said, I don't deal with that stuff.
That's fine. So I was not here Friday, so talk to who? Sorry. Messengers?
Mazen.
Okay.
Yeah. Alright guys, so let's start with the core of liver problem, which is cirrhosis. Okay, cirrhosis. Now liver cirrhosis or hepatic cirrhosis what's the underlying cause? What caused liver cirrhosis? Alcohol. Well, let's see, what is cirrhosis first of all? Let's not even go to the risk factors and cause. What's cirrhosis? Fibrosis. So somebody saying cirrhosis sounds like fibrosis, sclerosis. Okay, so cirrhosis, fibrosis, sclerosis. Somebody saying they're all three the same. Sure, okay. So what causes fibrosis? What is fibrosis then? Okay, so now there's some other students, they're saying, I'm just trying to make a story. There's some other students who are wearing a cap like me. This is not a cap, what is this? Beanie? Honey, mean you're in trouble. Beanie? We're wearing beanies?
Yeah, you're good.
Okay.
Believe me.
And Yusuf too. You know, he's wearing beanies. Okay, now, so they're saying fibrosis is simply replacement of viable tissue, or let's say, in this case, let's say cells. Let's say hepatocytes, replacement of hepatocytes. Hepatocyte by collagen. That's correct. Okay. So cirrhosis literally means scar tissue, right? And that's what you were saying. It means scar tissue. Is scar tissue living or non-living?
Living, but without action.
It's not a cell. It's not living.
It's not living. It's not living. When you replace living with non-living, what happens? Death. So that cirrhosis technically means part of the liver is dead, done, non-functional. So by collagen, of course. Now, let's define hepatic cirrhosis. It is complete destruction of hepatic architecture. You know, architecture means shape, function, everything is done. It's like demolishing a building. There you go. So cirrhosis, fibrosis, sclerosis. So please understand that. Cirrhosis means complete destruction of hepatic architecture. Do you guys watch Seinfeld? Who's the architect? George, right? George is the architect. So, I don't know why I just correlated that. I have no idea. It just came out of nowhere. Do you guys know who's the richest actor on earth? Seinfeld. Yeah. Seinfeld. He's even getting paid for it today because there's reruns and all that. You know who's the second highest? You probably. The person you like. Shah Rukh Khan.
Shah Rukh Khan.
Yeah. Okay. All right.
It's my favorite.
There you go. He's the second richest actor.
He deserves it.
He deserves it. All right, guys. Now let's go. So cirrhosis means complete destruction of hepatic architecture. What does that mean? Do you think you will see lobules? No. Especially the portal triads are done. If the portal triads are done, what do portal triads do?
Bring blood and take away labile.
Good. There are tubes responsible for flow. If they're destroyed and replaced with cement and scar tissue, what happens to the flow of blood and bile? Decrease and obstructed. So that automatically be looking for two things. Automatically, when your bile ducts are destroyed and your portal vein is destroyed, you'll be looking for two things: portal hypertension and jaundice immediately. I don't have to even tell you that, my dear friends. I don't even have to tell you that. You can make that conclusion on your own. No portal triad. The liver will go because of ischemic attack. No blood coming, not enough being drained, and not bile being made or conjugated. Done. But let's go now. We'll go with causes and then we'll go with complication of cirrhosis. What causes cirrhosis? What causes this damage? Of course, inflammation. Inflammation leads to cirrhosis. Look, so inflammation could be acute. Are we good so far? Acute inflammation, and it becomes what? Chronic, and chronic becomes what? Cirrhosis. Which means repetitive inflammation, repetitive irritation, repetitive damage, injury to hepatocytes will eventually lead to what? Cirrhosis. And eventually cirrhosis can become, oh my god, cancer, hepatocellular carcinoma. Okay, eventually, yes.
Is it damage to the hepatocytes or the stellate cells?
Oh, satellite cells,
Sorry.
they produce actually collagen. Okay, and then it's not damage to them, it's superactivation of them. Yeah. Now, she reminded me of something. You see, in the lobules, the macrophages of liver are known as what? Kupffer cells. Kupffer cells. Yeah. Sometimes they don't have the P, but Kupffer cells. The P is silent. Kupffer cells. These are macrophages. So now, if these are macrophages, okay, so macrophages have these granules. They're monocytes, right? When they're activated, what do macrophages produce? Good job. Interleukin 1. Interleukin 1 is pro-inflammatory. Now, what would irritate these cells? Iron. Iron deposits. Copper deposits. Okay? Let's say ethanol. Ethanol. Toxins. Let's say hepatitis B virus. Hepatitis C virus. All of these are toxins. Therefore, macrophages will do what? Swallow them. Now remember something about macrophages. Macrophages do not discriminate. They will eat anything and everything that is foreign to your body. Or when it accumulates, abnormal accumulation, debris product, garbage. Who clears it? Macrophages. When you have too much iron deposition. You heard of the term known as hemochromatosis. So this refers to hemochromatosis, which is a disease. I'll talk about hemochromatosis there. Hemochromatosis. Copper is Wilson's disease. Too much copper. Ethanol is alcohol, chronic alcoholism. This is infection, this is infection. All of these stimulate macrophages. Hepatic macrophages. And hepatic macrophages will produce what? Interleukin 1. And interleukin will cause what? Inflammation. Inflammation will cause what? Damage to cells. And damaged cells should be what? Replaced by new cells, because damage should be repaired. And then those new cells are still not mature and they're even more sensitive to what? Alcohol, virus, or copper or iron. So again, these are all the toxins. These will be the risk factors. So who's at risk of cirrhosis? People who drink a lot. I mean, I shouldn't say drink a lot. Alcoholics. Okay, regular alcoholics. Now there is not much of a correlation between people who drink once in a while and cirrhosis. There's not much. At least I don't know of it. But chronic alcoholics are a huge risk of hepatic cirrhosis. Okay? So now, that's number one cause. Actually, in North America, the number one cause of cirrhosis is what? Alcohol. What's the second cause? Hepatitis C in North America. Okay, and third world countries, what's number one cause? HBV, hepatitis B. Alright, now, hemochromatosis and copper, these are genetic conditions, so that's in children. And let's include one more thing, alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency. I'll put a negative sign. So these are the people at risk of cirrhosis, hepatic cirrhosis. Now I'll discuss each one of them in detail. I'll discuss each one of them in detail. Good? But understand the pathophysiology is macrophages will release interleukin-1. Interleukin-1 will cause what? Irritation, inflammation, and that will lead to eventually cirrhosis. Repetitive. It's not one-time inflammation. It's not two-time. It's repetitive over a long period of time. So inflammation over a period of 10 years could lead to cirrhosis. Over a period of 6-7 years can lead to cirrhosis. Okay, so it's not overnight. It's not a month. It's not 1 year. It's a long period of time of exposure to the same toxin over and over and over again. Yes, sir.
So stellate cells don't have nothing to do with liver cirrhosis?
It has to do with it. They produce collagen. They're fibroblasts. They are fibroblasts. Satellite cells in this area are immature cells. They can mature to become fibroblasts. And who makes them? Interleukin-1. Interleukin-1 activates this fibroblast. The fibroblast will start producing collagen. And it's collagen that leads to cirrhosis. And you'll find these cells in an area known as what? They're spaces. Spaces of Deci. Excellent, excellent. Okay? You can call them, sometimes they're called etho cells as well, small cells. Okay? These cells, they're usually inactive. Who activates them? Injury, trauma. Okay? They shouldn't be activated normally. They're there. They're there to repair. But then we go out of hand. Let's say, you know what? Think of it this way. So, let's say there's a storm. I hope not. There's a storm or something and some areas are destroyed or pavements and whatever. And then you produce, and the trucks that make cement and stuff, and they start pouring cement upon cement upon cement upon cement. So much. And eventually that cement solidifies. We'll be all trapped here. That's the idea. If etho cells or fibroblasts do their job properly, they're not overstimulated, it wouldn't be a big deal. But when they're overstimulated, they have too much product, and that product will solidify and become cirrhotic. And there's no diffusion. Everything is misshaped and destroyed, replaced with scar tissue. Okay? Okay. Alright. So now, understand cirrhosis. Cirrhosis is not overnight thing. It's not one day thing. It's not a 3-day thing. It's a long-term exposure to the same thing. Okay? Whether it's diet, lifestyle, or infection, or alcohol. Okay. Now, let's go back to the risk factors. So who's at risk? People who have viral hepatitis. Hepatitis C virus, hepatitis B virus, and hemochromatosis. Now look, hemochromatosis is iron overload. I'll just say iron overload. Copper overload. Copper is with CO. The symbol is Cu. Copper overload, which is Wilson's disease. So this is hemochromatosis. The disease, we'll discuss it soon. Hemochromatosis. And copper overload is known as Wilson's disease. Okay, so that's for this. And ethanol or alcoholics, again. Ethanol. Chronic ethanol use. Chronic ethanol abuse. Not 1 day, not 2 days, not 1 year. Long time. Okay, these are alcoholics who are at risk. Not binge drinkers, not occasional drinkers, not social drinkers. Alcoholics, alcoholics, alcoholics. Again, does it mean that, random drinkers cannot be? I mean, they could have alcohol plus a viral infection plus something else. All of them will accumulative effect. But there is no strong correlation between random drinking and cirrhosis. Okay. All right. Alpha-1 antitrypsin deficiency. All right. We cover this. Okay. See, symptoms and signs of cirrhosis are not difficult. It will make sense to you, but let's discuss this. Now, to understand if it's hepatitis C virus, it is RNA virus. Know that it's RNA virus. Single-stranded RNA virus. Okay. Hepatitis C virus is RNA virus. Single-stranded RNA virus, and it has envelope. Okay. Now, hepatitis B is DNA virus. DNA virus. So immediately know the difference. Immediately. Okay. For our purposes, for our purpose to identify what's the cause of cirrhosis. If you find viral DNA in a person's biopsy taken from hepatocytes or liver, then it's obviously caused by who? Hepatitis B. If you find in that biopsy tissue RNA, then it's what? Hepatitis C. Now you have 4 hepatitis: A, B, C, E, D as well, but D is no big deal. E and A are never chronic. Never chronic. They're self-limited. They're always acute, so they cannot cause cirrhosis. Only B and C causes it. B in 20% of the time will lead to cirrhosis, and C 80% of the time. Chronic hepatitis and then maybe cirrhosis. So C is more the risk. C puts you more at risk of what? Cirrhosis. Now when I say the 80%, it's not cirrhosis. So C will 80% of the time become chronic. B will 20% of the time become chronic. So C is more likely to become chronic. And chronic hepatitis can become cirrhosis. So you might have C your entire life, you might never have cirrhosis. No big deal. Especially if it's under control. Especially if your diet are proper. If you're not so anxious about it, if you're not stressing, if you're doing other proper measures, it might never go to cirrhosis. As a matter of fact, it might even decrease. The progression might even slow down. There have been rare cases when it's reversed. But again, it all comes to your mental strength in your physical behavior. So, but cirrhosis overall is non-reversible. Cirrhosis is non-reversible. The thing in liver is, liver has the potential to regenerate. Liver has the potential to regenerate. If you have 25% of liver functional, you can still have liver becoming back to normal. Meaning if you remove about 80% of the liver, or 75% of the liver, that 20% can regenerate. It's okay. So liver has that potential. Which means when it comes to cirrhosis, it could be reversible. Difficult, but nonetheless, you have to be a crazy person, do a lot of crazy things, good crazy things, but it's reversible. At least stay away from those things that are causing or put you at risk of cirrhosis. So that's one. These 2 viruses, if I choose amongst these 2, who's most likely to lead to cirrhosis? C. C for cirrhosis, C for C. Hepatitis C. Yeah. Alright. RNA and DNA virus. Good? Now, know that hepatitis C virus is primarily transmitted through blood. It is primarily transmitted through blood.
Which one?
C. Serum. Okay. C is primarily transmitted through circulation or blood. B. STD. B is STD. Still it's transmitted through blood, but it's STD as well. Sexually transmitted as well. So B, C is not a big deal in pregnancy. B is more a big deal in pregnancy. A mom can transmit it to her baby. Now when babies have Hep B, it is 80% of the time will become chronic. Unlike adults. In adults, it's 20% chance of B becoming chronic. In children, 80% risk of becoming chronic. Okay, that's why babies have to take Hep B vaccines, right? Alright. Does hepatitis C has a vaccine? No. B has a vaccine? Good. Okay. So iron overload, hemochromatosis, usually it's iron transport problems. The defect is in iron transport problems when you discuss it. Hemochromatosis, which is part of liver, I'll discuss that. Copper, Wilson's disease, is copper transport problem. It's genetic. The gene is on chromosome 6, so it's defective. As a result, you cannot transport copper properly, and it accumulates in tissue. Okay, so again, we'll discuss that. Ethanol abuse. Now, this will be, if you look for risk factor, this is usually sexually active. Young men who are at risk for hepatitis B virus. Hepatitis C, drug abusers. Sharing needles or blood transfusions in third world countries where blood is not screened properly. Or just infection. With hepatitis C from a different thing. But usually in this country, it's drug abusers, needle sharing, and blood transfusion are more at. Now, because blood transfusion used to be a huge risk factor in the 80s, not anymore. Not anymore because all bloods are screened. Not anymore. So now, hepatitis C shouldn't be that big of a deal. If it happens, it's not because of blood transfusion. It's because of maybe blood mixing and stuff like that. Okay? Or somebody made a mistake and didn't screen it properly. So it's usually mistakes. Genetic ethanol abuse. Now this is usually alcoholics, so over the age of 50. Patient over the age of 50 is mostly men. Okay. Okay. Alpha-1 antitrypsin deficiency, children or young. Okay. They will also have emphysema.
Isn't that also genetic?
Yeah. That's why I said children. They will have emphysema. So we'll discuss those. Each of this is a disease by itself. 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 This is a disease. So we'll discuss them in their appropriate locations, right? They're all diseases. So these major diseases leads to what? Liver failure. Now think of it this way. Every disease, the end result should be what? When it comes to liver diseases, all liver disease, the end result will be cirrhosis. If it's not resolved. Same thing with heart diseases. All cardiac disease will eventually lead to what? CHF. Heart attack will lead to CHF as well. Every cardiac disease, the end result is heart failure. The heart fails and it gives up. Every liver disease eventually will lead to what? Liver failure. Liver gives up, it's done. So that's why cirrhosis is the core of all hepatic diseases. Okay, so you know the risk factors. Let's go to what would be this patient with cirrhosis, what would they be complaining of? Jaundice, of course. Jaundice. Why jaundice? Now this jaundice, what causes jaundice? Accumulation of bilirubin in your skin. Good. Accumulation of bilirubin in your skin. In this case, what's the cause of bilirubin accumulation in your skin?
You can't produce it.
Unconjugated bilirubin. So conjugation is the problem. Thank you. Conjugation. What happened to hepatocytes? They are replaced with scar tissue. If you're supposed to have 1 million hepatocytes, with cirrhosis you have 1,000 maybe, 2,000, less than a million. I'm giving you a number. Why am I giving you a number? Not for you to memorize, just to give you some sort of scale. In cirrhosis, the number of hepatocytes is decreased compared to the normal level. And if I don't give you a number, some sort of number, you'll be always crazy. People like to have some sort of limit to everything, right? I'm giving you just hypothetical number. Let's say normal liver has 1 million cells, hepatocytes. In cirrhosis, they're decreased to 100,000, let's say. Are 100,000 enough to do the job of 1 million? No. For example, if a hospital requires 100,000 doctors and you only have 10, what will happen to most of the patients? They will suffer. Same thing. So liver is not capable of converting unconjugated bilirubin to conjugated at the same rate as before. It doesn't mean it's zero conjugation. Okay? No, you have some conjugation, but it's not effective enough, of course. So as a result, bilirubin will accumulate in blood. What kind of bilirubin? Unconjugated bilirubin. So that's because of the conjugation defect, unconjugated bilirubin. So that's one thing. That's because of lack of hepatocytes. True? That's because of decreased number of hepatocytes. But at the same time, what's destroyed? The portal triad. The portal triad has one of those. Triad is what? Bile canaliculi. If you have less bile canaliculi, can you even transport or secrete bile out of liver into gallbladder or to duodenum? No. So that means you will also have conjugated bilirubinemia, both. So you will have accumulation of both types of bilirubin. Number one, you cannot conjugate it. Number two, you cannot secrete it. So both are problem. So you'll have bilirubinemia. Bilirubinemia. Okay? So look for that. And this bilirubin, when it accumulates in your skin, it will cause yellow discoloration. And if it accumulates in children and their brain, it will cause something known as, starts with K. Connectors. Very good. Okay? Brain failure. Brain damage. Okay? Brain damage in children. In adults, it wouldn't cause much. Okay? And that's unconjugated bilirubin. See, unconjugated bilirubin, why do you have to even conjugate bilirubin, guys? Usually I'll talk about bilirubin in RBCs because it's a product of RBC lysis, right? Next term we'll discuss it. But what's the difference between conjugated and unconjugated? Thank you. There you go. Unconjugated is lipid soluble. Conjugated is water soluble. You see, whenever something is not soluble, it becomes toxic. So what does liver do? Yeah. You know when we talk about toxins, what does liver do to detoxify them? Make them soluble. Make them soluble. When you make something soluble, you can move it in plasma. When something is soluble in water, you can move it. You can transport it in blood, correct? And where would they go then? Kidney, and then excrete it out of the body. Unsoluble things cannot be transported properly. So unconjugated, insoluble. Conjugated is soluble. So which one is more damaging? Which one is more dangerous? Unconjugated bilirubin. Unconjugated is more dangerous. Good? Alright. So I should have said in this case, let's put it this way. So as a result of this cirrhosis, we will have bilirubinemia. This is one problem. Bilirubinemia. Abnormal accumulation of bilirubin where? In plasma. And let's call it hyperbilirubinemia. I have no control over my fingers. There you go. That's much better. Hyperbilirubinemia. 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 Hyperbilirubinemia will lead to what? It will lead to something yellow. Jaundice. And how would you identify jaundice? You look at skin. Anything else? Where in the eyes? Sclera. And how about the conjunctiva? The inner of your eyelids. Okay, good. So look for jaundice. What else would it lead to? Hyperbilirubinemia. What else would it lead to? It is bilirubin that gives stool. Pale stool. Pale stool. Thank you. Pale stool. Unconjugated bilirubin will lead to pale stool. And unconjugated bilirubin will be eventually cleared by the kidney because it cannot be, especially if it's obstruction. Whenever you have obstruction, that means bilirubin cannot be secreted into where? Into the duodenum. So as a result, less bilirubin where? In the intestine. So stool will not get its color, dark color. Now, if you cannot, there's only two ways to get rid of stuff, right? There are two pathways when you can excrete things out of your body. One is intestine or stool, the other one is urine. Sweat maybe too, but that's not so effective. So if you cannot clear bilirubin through stool, obviously most of it will be filtered in the kidney. If it's bilirubin that gives dark discoloration, and now you have less bilirubin in stool, stool will be light, pale, and you have more bilirubin excreted through urine, so urine will get what color? Dark. Very good. Dark urine. Okay. So that's simply because of what? Hyperbilirubinemia. All of this is, so this does not tell you it's a liver problem. It just tells you hyperbilirubinemia. There could be multiple things causing hyperbilirubinemia. Alright. So that's one thing. We're done with at least this. So one function of liver is to secrete bilirubin and conjugate it. In cirrhosis, you have both defects, secretion and conjugation. So as a result, you will have conjugated and unconjugated hyperbilirubinemia. Please remember that when we do tests, we look for direct and indirect and total. Total is a combination of direct and indirect, or total is a combination of conjugated and unconjugated. The normal concentration of bilirubin should be 1.2 total. 0.4 is unconjugated and 0.8 is conjugated, if I remember correctly. But you get these values regardless on the exam. You will get those values on the exam, okay? Those of you who don't have for your final exam, or in this exam coming up Monday, if you don't have those, the laboratory values, please get them somewhere. I email it to everybody, but I'll see, that was a long time ago. If you guys have those emails, please can you send it to those guys who don't have it? I think I sent you the email. I'll look for it. It'll just remind me. Because on the exam, you should print it out and bring it. So you don't have to memorize the values, okay? That's not your job. If you do, it will speed up the time. You'll just take the exam much faster. You won't have to waste time on flipping through pages and looking for stuff. That's the benefit. But you don't have to memorize. Okay. So that's one function of liver. We're done with this. Any other function of liver? What's other function of liver? Storage. Now, liver was able to store what? Glycogen and lipids. So in cirrhosis, you will not be able to store. So what's the big deal if liver cannot store glycogen and lipids?
So you don't have as many glycogen stores.
Yeah. So this will only become symptomatic when you're actually hungry, when you don't eat frequently. Otherwise, it wouldn't be a big deal. Because liver will cause glycogenolysis, right? Only between meals, when you're hungry and you have to restore your plasma glucose level. And ketones defect as well. So that's one. Anything else? Cholesterol clearance. Cholesterol excretion, cholesterol metabolism. Liver does it, yes. So now, if liver cannot do, so let's go to plasma protein then. Let's just talk about plasma protein in that case. So he's talking about apoproteins. Apoprotein or apolipoproteins. So in this case, liver is unable to make a lot of apolipoprotein or enough. So decreased apolipoprotein will lead to what?
Decreased liver absorption.
It will lead to?
Decreased.
There you go. Increased plasma cholesterol. Now, apoprotein E, where is that one made?
It's required for.
Where is it made?
Oh, in the intestine.
Good. C,
Also intestine.
B48.
Also intestine.
Good. So absorption is not affected. Liver makes the other ones. So the apoprotein made by the liver are plasma proteins that's supposed to carry cholesterol in plasma. If you don't have the taxis and the bicycles and the trains, what will happen to Chicago downtown? It wouldn't. Okay. It would be overcrowded with people walking on streets. Right? So now if you don't have the apoproteins, that means cholesterol will be swimming around freely in plasma. And that puts you at risk of what? Atherosclerosis. Atherosclerosis. Okay? No. No. Type 2 hyperlipidemia means LDL receptor deficiency. It's genetic. This is acquired. Yeah. Cool. Cool.
But they're both
Huh?
hypercholesterolemia.
Yeah. Okay. Alright. Which one? The other one is familial. Type 2 is familial. This is non-familial. This is acquired. This is alcoholic type. Okay. Alright, so that's apoprotein. Now, apoprotein, they will lead to increased atherosclerosis, right? Write it down. Atherosclerosis puts you at risk of heart attack. It puts you at risk of? Very good. And it puts you at risk of? Strokes. Okay, so strokes and heart attacks will increase in cirrhotic patients. The risk of them doesn't mean they will 100% get it, right? Doesn't mean that. Tell me other plasma protein. Albumin. Very good. Now, albumin is the primary plasma protein. 80% to 90% of all plasma protein is what? Albumin. About 7 out of 7 grams of plasma protein, roughly speaking, 5.5 is all albumin. If you don't have albumin, what happens? So now,
Decreased carrying capacity, decreased oncotic pressure.
that's the one. Thank you. Please say it loud.
Decreased oncotic pressure.
Good. See, in plasma we have proteins, right? Within blood vessels we have proteins. Let me do this. Normally in blood we should have albumin. Okay, let's say this is the normal concentration. When you have albumin in blood, that means this creates a pressure known as oncotic pressure. Okay, so particles produces a pressure known as oncotic pressure. Oncotic, that's not oncotic. Oncotic pressure. Oncotic pressure is pressure produced by who? Particles. Hydrostatic pressure is pressure produced by what? Water or liquid. Hydrostatic pressure is a pressure produced by water. Oncotic pressure is a pressure produced by particles. Let's understand these two first. Write it down. Hydrostatic. Hydrostatic. Two pressure we need to understand. Hydrostatic pressure is pressure produced by liquid or water. Oncotic pressure is pressure produced by solid particles. Good? Alright. And the pressure increases as the number of particles increases. Oncotic pressure is directly related to the number of particles. Hydrostatic pressure is directly related to the amount of water. Let me give you two things now. I'll give you two things. Here is a beaker A, or cup if you guys don't like beakers, cups B. Now both of them are full of water. Water is blue, right? Is it blue? Yeah. Okay. Flood. That was flooding. Okay. So both have the same amount of water. Let's say both have 1 liter. 1 liter. Both of this have 1 liter. Now in beaker B we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 particles. In here we have only 4 particles. Which one has more oncotic pressure?
B.
You're just like me. Ahmed just like me. That's how we're raised. We don't verbally say, we point. When I go shopping, I don't read labels. I go by pictures and colors. When I go to restaurant, I don't remember their names. I know how to get there, honestly. It will take us time. It's okay. All right. So, who has more oncotic pressure? B. Now, who has more hydrostatic pressure? A. Compared to particles, you have more water. See, when we talk about water, we're not talking about pure water and pure particles. We're talking about comparison. If you have more water, less particles, that beaker or that solution will have more hydrostatic pressure. If water compared to solid particle is more hydrostatic pressure. If you have more particle compared to water, you have more oncotic pressure. Is that okay? Do you understand the concept? It's not in absolute pressure. It's relative pressure. You have to compare it to something else. Pressure outside or inside, you know? So now let's say, in this case, let's do this. I mean, I should have made him yellow and to differentiate between. I guess you guys can see. There you go. Let's assume B. Now I'm going to erase this just to make sense to you. Let's say B is extracellular space. Extracellular space. What's another term for extracellular space? Yes. Interstitium is actually the space between cells. When you say extracellular, vessels are also included in that. So we'll use interstitium. Interstitium. Much better than extracellular. Thank you, honey. Okay. Interstitium. Interstitium. Interstitium is the space between cells, excluding blood vessels. Okay? So let's say this beaker is interstitium. And this is, I'll make it red, but just for the sake of understanding, because blood is red. Okay, so red is blood, or plasma in this case, plasma. Okay, both are made of water. Both are made of water. Okay, both plasma and interstitium is made of water. Now guess what? Generally speaking, in blood, where is this? There you go. The oncotic pressure in blood and interstitium should actually somehow match. It should match. It should match. The difference should be in the hydrostatic pressure. The difference should be in the hydrostatic pressure. Now, it depends when we talk about capillary, that is venous end or arterial end. The oncotic pressure varies. Other than that, it's simple for now to keep it, okay? So I know what you're thinking, but in the arterial end, just to convince you, in the arterial end you have more oncotic pressure, and in the venous end you have less oncotic pressure. Okay, so fluid will be exchanging. Okay, so it varies in that. But protein should never leak. Protein should never leak. Protein should never leave plasma. Remember, albumin never leaves plasma. It stays within blood vessels. If they do, they are returned by lymphatics. Understand this concept. The only thing that can lead, and you know what, I'm going to make this a little bit more easier. Let's say these are the interstitium. So just like space, not to confuse it with another vessel. Okay. Now protein should not leak. Protein should not leak. If they do leak by mistake, they will return, lymphatic will bring it back. So as a result, the oncotic pressure of blood should be always constant. Always constant. And the oncotic pressure of interstitium should always be constant. Always be constant. Okay? Now when you talk about some areas, it's different. Like in kidneys, the oncotic pressure is different compared to pulmonary capillaries. But in other areas, it's balanced. Okay? Now, in this case, in cirrhosis, remember, the only thing that can leave here is what? The only thing that can go in and out is water. Protein cannot leak. We established that protein cannot go in and out of blood vessels. So for whatever reason, let's say in cirrhosis, you make less plasma protein, right? In cirrhosis, what happens to plasma protein? They're decreased. There's less plasma protein. If there's less plasma protein, what happens to capillary oncotic pressure? Decreases. If capillary oncotic pressure decreased, that means you have more water in capillaries, true? So now water will go where now? Water will go towards interstitium. It's no longer balanced. Yeah. So this is what will lead to edema. Okay? This is what will lead to edema. So always cirrhosis patient will have huge abdomen or ascites and swelling. And that is because what? Decreased oncotic pressure, decreased oncotic pressure, decreased oncotic pressure. They have less plasma protein. So obviously, see, oncotic pressure retains fluid. Oncotic pressure attracts water. If you have less oncotic pressure, water will not be attracted as much. It will not come in. It will leave. Okay, so this is the reason of decreased albumin. This will lead to edema. What kind of edema? Can you name some edemas for me? There's different types of edemas.
Ankle.
Now, this will not be central edema. This will be what? Peripheral edema. What does central edema mean? Lungs. Central edema means lung. So this is not pulmonary edema. This will not happen in lungs that much. It's primarily generalized edema in the abdomen, ankles, okay, face, everywhere else. In lungs, it does occur, but it's small. Okay, so now what is ascites? Abdominal edema. Abdominal edema, such that you can see with your own eyes. Not the fluid. The fluid when you when you do percussion of the abdomen, or when you shift the abdomen, you will see some sort of shift, but you will see distension of abdomen, distension. Okay, you heard of, you seen people having bare bellies, right? That's what it is. Okay, it's because of this. Okay, on top of the alcohol tends to attract water to itself. Okay, all right. So ascites edema. Now this can lead to what? What else? This edema can lead to peritonitis. Peritonitis. Okay, so that's because of albumin. But you know what? I want to talk about something else. Not only does albumin leads to edema and ascites, okay, portal hypertension as well. I'll just put in bracket portal hypertension, which we'll discuss in a bit. Portal hypertension.
It's also due to albumin.
No. Portal hypertension contributes to ascites. Okay, and leg or ankle edema, and splenic edema, liver edema. Okay, portal hypertension will lead to that too. Okay, so portal hypertension will lead to splenic enlargement. Abdominal edema is known as what? Ascites. It would not lead to like edema around your eyes, facial. That is because of albumin deficiency. But ankle edema, anything below the liver, is portal hypertension. I'll come back to this because portal hypertension causes a lot of other problems too. So I want to still stick to plasma protein. What's other plasma protein? One more. You said complements? Now complements are a group of proteins. They're a group of proteins, and they're used to deal with infection. Okay, they need to clear infections. Very good. So complement gives you three products at the end of the day. Complements give you three things. One is known as MAC, which kills bacteria. That's one thing. Complements kill bacteria. Okay, so MAC, just write this down for now. MAC stands for membrane attack complex. Membrane attack complex. Membrane attack complex. Membrane attack complex. Meaning MAC attacks membrane. Membrane of what? All cells. Indiscriminate. It attacks what? Cell membranes. What do they do to cell membranes? They puncture them. Imagine you have 10 knives. MAC is made of about C5 to C9, about that's 5, 6, 7, 8, 9, 5. 5 protein. If you take 5 knives and you put them in a huge, like a tire, you punch them and you make a hole. That's what this will do. 1 knife, 2, 3, 4, 5, 6. So they go like this and they punch a hole into a cell. Membrane attack complex. And what happens to the cell? It bursts. It bursts. It leaks fluid. It bleeds in a sense. Like cells don't bleed, right? But they bleed like how we bleed in that sense.
It's like a balloon. Okay.
Yeah. Okay. That's what MAC does. So that's one reason of complement. But complements will do this to who? To foreign cells, not to your own cells. They shouldn't do that to your cells. And they won't. They won't do to your own cells. And complement can do this only where? In plasma. They're plasma protein. They cannot do this in tissue. Okay? So that's one. And then you have one more part of complement known as C3b. Yeah. I'm coming to that. Yeah, I'm coming to it. So I'm giving you 3 products of it so you understand. If you have complement deficiency, all 3 things should be affected. Okay? So number 1, complement, MAC attacks what? Cells, abnormal cells. Or in this case, abnormal cells could be bacteria. So let's stick to bacteria, okay? C3b is required for, so that's three things. MAC, C3b, and then C5a. Okay, C5a. You see that's, the C stands for complement. Complement, complement, complement. Complement type A, complement type B, and then there's about 13 complement products, so of course, 20 protein complements, so they're labeled 1, 2, 3, 4, 5, 6, 7, 8, 9, and 20. And then A and B, A and B. Okay? The different fragments. Ignore it for now. Just understand what I'm telling you. Because I'll discuss complement next term in details. We'll spend a whole day on it. Good? For now, the job of C5a is recruitment of white blood cells. The job of C5a is recruitment of white blood cells to the site of injury. C5a is a signal. Hey guys, we have trouble here, please come help. So who comes to help? White blood cells. So C5a is recruitment. Now, think about it this way. If you want to bring a lot of cops or ambulances to this area, what do you have to do to the streets and roads and street lights? Yeah, make sure everybody's on the side. And in this sense, it's vasodilation. Vasodilation. So C5a also causes what? Vasodilation. C5a will cause two things. Number one, vasodilation. And it will cause recruitment of white blood cells. But recruitment can be useful if you have tiny little blood vessels. So increase blood flow. At the end of the day, C5a is pro-inflammatory. If you understand what is inflammation, you're okay. C5a is pro-inflammatory. Pro-inflammatory. And it causes shock. It will cause shock. And it will cause rash on your skin because increased blood flow. We'll come to that point. But for now, inflammation. Good? C5a is pro-inflammatory. C3b. C3b. Let's go to C3b. C3b is specifically needed for what? Opsonization. Write this term. Opsonization. Let me write it down. So C5a was for inflammation. It's pro-inflammatory. C3b is for opsonization. Opsonization is enhanced phagocytosis. All of you understand phagocytosis, correct? Phagocytosis means swallowing, eating. Now C3b is enhanced, improved phagocytosis. Okay? But this only applies to neutrophils and macrophages. Which means neutrophils and macrophages can swallow bacteria much better with the help of C3b. Without it, not so good. Okay, let me give you something more. How hard it is to catch fish with your bare hand. Very difficult, right? Every time you catch it slips, right? There are some bacteria, not all, some bacteria that have capsule. Okay, bacteria have capsule. And that capsule is very slippery. It's slippery. You know when you eat candy like hard candy and you spit it out and you want to hold it. Can you hold it? It's very slippery. Candy is made of what? Sugar. Capsules are also made of sugar. At least that will help you remember. Capsules are also made of polysaccharide or sugars. Bacterial capsule, not anything else. So those bacteria that have capsule, they are very difficult for macrophages and neutrophils to catch them and then swallow them. First you have to hold on to something or catch them and then swallow them. True? So capsular bacteria are difficult to swallow without C3b. C3bs are like hooks. It will hook onto it and hold on and then it'll swallow them. So now complements helps in what? One in recruitment and inflammation. C3b helps in swallowing phagocytosis of capsular bacteria. Are we good so far? MAC punches holes in cell membranes. Good? It punches hole in cell membrane. Now it's becoming a little bit more information for you now. There are again two groups of bacteria. Those bacteria that have a thick cell wall. Okay, think of complements as knives or swords. Okay, if you wanna or yeah, knives is a good, like, you know, do you guys ever watch Element channel? bipolar girls, what did they do to the boyfriend's cars? Smash the tires, right? If the tire is this thick, what would the knife do? Nothing. So it's those bacteria, guys do it too, so not to pick on girls only. There's bipolar guys too these days, a lot of them. Okay. So if the bacterial cell wall is this thick and the complement is this long, those bacteria that have thick cell wall will be ineffective. So complement MAC will only be effective against gram-negative bacteria, which have thin cell wall, gram-negative bacteria. Okay? Especially what Muhammad said, and I heard him, Neisseria meningitidis, Neisseria family. Especially Neisseria family. So let's write it down. So MAC protect against Neisseria. Neisseria, this is a family of bacteria, two major categories. Gonorrhea is in this category and meningitidis. Okay. But anyhow, so now look, we need to understand this to understand cirrhosis. Complements cause inflammation. Complements protect against capsular bacteria. Complements protect against who? Neisseria meningitidis. So in this case, in cirrhosis patient, we don't have complements, or at least they're decreased. What would happen? These patients are at risk of what? Infection, especially who?
Capsular bacteria.
Capsular.
And Neisseria.
And Neisseria is capsular, so let's just write Neisseria for now. But you need to understand the concept. So specifically, Neisseria, meningitidis, Neisseria, and gonorrhea infection will increase in this population. Specifically. So cirrhotic patients are at risk of who? Neisseria infection. Are we good? Does it make sense? Okay. I know it took long, but it had to be done. Okay. We'll finish the plasma proteins and then we'll take a break. Any other plasma protein? Clotting factors. Clotting factors. All clotting factors with exception of 8 are made by who? Liver. And their plasma protein, you see, complements in plasma, this protein are swimming, inactive. Complement in plasma just swimming, they're inactive. The only time they will become active when you need them to be. True? Same thing with clotting factors. Clotting factors are also plasma protein. They're 24/7, year round. In your lifetime, right now as we speak, clotting factors are swimming. They're plasma protein, they're in plasma. How come they don't cause clotting? They need to be activated. How come complements don't cause problems in your plasma? Because they need to be activated. So again, there are things that will activate them. So normally clotting and complement factors are inactive in plasma. Please understand that. It makes sense. Logic. It's very logical. You know, you only need them when you only activate them when you need them. Okay, so clotting factors. If liver cannot make clotting factors, and the function of clotting factor is to form clots or seal cuts or prevent bleeding, that means this patient are at risk of what? Increase bleeding. They're more at risk of bleeding.
Would they ever acquire hemophilia?
No.
Or is that just a weird?
Well, I mean, it's the same thing. But in this case, not just one, not 8 and 9. It is all factors. So the bleeding here is worse than hemophilia.
Oh, it is worse.
Okay? Depending on which stage of cirrhosis you are.
Depending on how much.
So in a sense, these complications of liver cirrhosis are asymptomatic unless you develop like gonorrhea, meningitis, or you have a shock.
Only the complements.
Yeah, that's not the complications of liver cirrhosis are only the complements and clotting factors.
Yeah. No, not clotting factors. See, clotting factors has nothing to do with infection. So if I understand it correctly, you're right. If you say generally, these things will develop when you have need of those factors. Yes, that's true. Yeah. You will not spontaneously bleed. But you know what? With clotting factor deficiency, you can spontaneously bleed into your joints. Because joints goes through friction and torsion. So for example, you know what? If you hit your hand against the wall, right now nothing. But in cirrhotic patient, you might build a bruise immediately. Okay, because bleeding cannot be prevented.
So HIV is only the recurrent or always have to go like paracentesis?
Yeah. Okay, so clotting factor will, I mean, cirrhotic patient at risk of what? Increased bleeding. Anything else? Yeah, plasmin is actually anti-clotting. Yeah. So overall, there's more clotting factor deficiency. Trypsin. Yeah, not necessarily. No. Trypsin is carried by neutrophils and pancreas. Okay. Effective. So that's the. Let's take a break. These are the plasma proteins. Okay. So albumin, complement, clotting factors, and apoprotein. We discussed them. And we'll come back to other function of liver.